The healthcare system is broken, but it doesn't have to be. This is Revenue Cycle Optimized by Infinix Healthcare. We discuss the latest challenges in the revenue cycle space and provide actionable tips on how to overcome them at your organization.
Good afternoon and welcome everyone to another episode of Office Hours. We're very glad to have everyone with us as usual. We're going to cover a topic today that I know is a plague to everyone out there when it has to do with revenue, and that is lessons from $10.6 billion in claim denials. It seems to be a very recurring theme. I was just at a conference earlier this week, which was mainly a coding conference, but looking into the revenue cycle, it seemed like everyone was talking about denials was just the number one enemy when it comes to revenue integrity. And this is certainly no exception. So I'm hoping that by the end of today's episode, many of you will understand, kind of the problems that are out there, why they are problems, as well as some tips maybe to help remedy some of those issues that are out there. I'm your host, Stuart Newsome. I'm the Vice President of Marketing here at Infinix. You typically will have a guest, but every once in a while I go it alone. Today is one of those days. And the reason we wanted to do this is because we are focusing on an article that was just recently released by Fierce Healthcare. And this article kind of reinstated some of my concerns to a topic, which is chasing dollars that should have already been paid, where the claim has been submitted and it's been rejected or denied. And there's a lot of effort to go after that to get repayment. So we're going to break that down a little further. I think, Candace, if there's a link that you could share with everyone, the Fierce Healthcare.com website, if you click on that link, it'll give you access to the full article. So feel free to read through that. The majority of it focuses on Medicare Advantage, but there's also a lot of good information regarding the effects on commercial plans as well as managed Medicaid, et cetera. So the reason that I'm the one that's speaking mainly on this because I really have a passion for this, recovering revenue, understanding where those denials have come from and the efforts that it takes to drive that revenue back in the door, chasing those claims that have been denied. And then more importantly, how do you prevent denials from happening to begin with? It's all about denial prevention, being proactive. If you joined us about 3 months ago, I touched on this subject, which was all about the cost of reworking a claim. And very few providers understand the cost of reworking a claim. And if you recall, if you joined that episode, if you didn't, I'll rehash it real quickly here for you. On average, it's about $25.20 to rework a claim. That's the national average that you can get from HFMA as well as MGMA. And there are certainly instances where that cost per claim is higher, or it could be conceivably lower as well, but on average about $25.20. So just remember that number. And if you look also, the national average has consistently been anywhere from 15 to 20% of the denial rate. I know some of you out there may have a much lower one. Most of you may fall into that average range, and some may be a little higher. When you apply all those numbers and you submit a claim and you're thinking, I'm doing all this work to get this claim back, there's a certain degree of success, not without frustration, but at least you're getting paid a certain percentage of that. And on average, only about 40% of the claims are ever resubmitted or ever fought for, or 35% are ever applied for appeals. So there's still a large percentage of claims that never ever get paid and are just left on the table. So how can you prevent that? And then when you count that cost, the cost of reworking that claim overall could cost, let's say you're 15 to 20 physician practice and you're doing roughly about 5,000 claims a month. And with a 12% denial rate at $25.20 per claim on average, you're looking at about $15,000 a month. That's a lot of money. That's substantial. And many practices don't really consider that factor when they're reworking their claims, when in actuality, you're still getting much less than you would when you consider that the 40 that I mentioned earlier could be a much less percentage when you factor in the work to go after those claims. Coming around to this article, it just, resurrected that fire into me, if you will. It kind of made me a little angry. It should make all of you angry as well. But to me, at the end of the day, it looks like, to some extent, a lot of payers, they're just going to deny claims because they deny claims. That's just what they do. It seems right off the top, especially when you see that many of them are also starting to use AI to deny claims. and not only use AI to adjudicate claims, I should say fairly to them, where most of them are being denied using that, but they also use the same AI processes, machine learning process to go back and retroactively audit claims to recoup payment that they feel you shouldn't have got paid for. So it's kind of a double whammy. You're getting your claims denied, but then some of the claims you're getting paid for, you didn't make sure you keep your hands on that revenue, that it doesn't slip through your fingers. So some of the staggering impacts that we see, that you'll see in this article, and just to get started with that, is it reported about $20 billion in administrative costs in 2022. Now, I will have to do a disclaimer. This is 2022 data. And like anything, I know we just started 2024, so they don't likely have 2023 data. It's always retroactive. I know some people, they always ask me, why are we talking about 2022 when it's 2024? Well, you got to remember, you don't have access to a lot of claim data from the previous year until a couple of months into 2 years after that data was accumulated. So of that $20 billion in administrative cost, this article, which was actually based on a blog by Premier, which is a vendor in the RCM space, vendor space, mainly in value-based care, that helps with the value-based care. But what they found is $10.6 billion was spent on disputes over denied claims that should have been paid or were eventually paid. So essentially, what that says is you were supposed to get paid for these anyway. And when they were disputed, the payer went, oh, yeah, we'll overturn these. But they just denied them anyway, betting on the fact that perhaps many of these claims are not going to be resubmitted at all. So there's a large percentage of that revenue that's still on the table because you just can't get to resubmitting every single claim or appealing every single claim. There were also higher denial rates. I know the average denial rate that they reported was still 15%, but when you break it down by payer types, it does tell a certain tale. So for Medicare Advantage, they reported about 15.7%. For commercial plans, it was 13.9%. Managed Medicaid was 15.1%, so still around that range, but surprisingly, Medicare claims were the lowest at 8.4%. So these denial rates really underline that extensive administrative strain and highlight the need for some targeted improvements and accountability for payers, but also, think about how can we or how can providers help alleviate those denials from happening to begin with. So let's break that down a little further. I like to look at it holistically, because percentages and numbers and people throw those out there and it's like, yeah, that's startling, but how can we break that down even further? So extrapolating the 15% overall rate to roughly about the fact that you think about it is 3 billion claims are processed nationwide each year. So that really suggests that there's an estimate of about 450 million claims per year that were subjected to denials. Okay. So among these, 54.3% were later overturned. 54.3%. So let that resonate with you. So that's a big issue. 450 million claims out of 3 billion were subject to denials. So many others may have ultimately been paid, but they just weren't not fully pursued for payment due to issues such as resource constraints. We know with the Great Resignation, there is a shortage of personnel out there. Along, you add the fact that there's probably some manual processes, some inefficient means of reworking of claims within your claims management system. These issues are out there. I have heard about these stories at the conference I just recently attended. It was HealthCon by AAPC, and a lot of chatter resulting in, how can we get our denials overturned faster? And my question was, well, how can you prevent those denials from happening to begin with? And this really adds to the burden of the substantial cost that they're adhering. Now, as I mentioned earlier, it was $10.6 billion spent of that 20 billion figure back in 2022. As a result of that, now remember, I said $25.20 per claim was the average cost to rework that claim. It jumps now to $43.84. That's almost double. So this financial burden of pursuing these denials is also distributed across payer types. So it varies, just like that denial percentage varied. So does the cost to rework those claims. Now, surprisingly, the cheapest, which this is amazes me, was Medicare. It's 79 cents per claim. I kind of also want to look at that data, see how they came up with that, because that's an astonishing number. But it really skyrockets from there. When the Medicare Advantage plans, they were at $47.77 per claim, with commercial claims really leading the way with $63.76 a claim. Now remember, that was the average based on 2022 data. Some may have been more and some may have been less. It's not necessarily the median, but the overall average. So this disparity underscores the particular challenges that many providers are facing today, particularly with MA plans as well as private payers. There's also some indirect cost that this article pointed out, and I agree with this. Often it takes a long time to recoup those claims. So you imagine this, everyone who's in denials management, they understand the issues and the pains with this, that every time you have to resubmit a claim, you may have to wait another 45 days or so before you get that payment in for that claim. So the cycle starts again. It took you, just as long to probably receive that denial, especially if there were some rejections and you had to then resubmit because you had to make some minor corrections to actually get that claim adjudicated. And once it was and denied, now you have to do some overturns and appeals, and that takes a longer process. So each time that process happens, on average, some of these providers are waiting up to 6 months to recoup that payments. Imagine they have your money for 6 months. So for hospitals, this can be very, very devastating, and it really affects the cash flow. And that cash flow really affects patient care. It affects flexibilities in reinvesting in that patient care. But also, these delays in claims processing can even extend patient stays in hospitals, which, as you all know, increases the risk of hospital-associated conditions, particularly in the transitions to post-acute care settings. So on average, these delays resulted in a 17% year-over-year drop in average days in cash in hand for hospitals. So just think about that for a second. And that's really going to be something that we try and hone in on to calls for remedy for a lot of this. So there was some call to action in that I also agree with, but also at the end of the day, as I state these, you may be nodding your head, hopefully, that yeah, we've heard this before. Where is the accountability? Even there's been some final rules and some proposed rules out there about how Medicare is going to help alleviate some of this, particularly with managed care plans. But there were about 100 partners, organizations came together that bonded together to urge CMS to have some oversight into some of these A plans. So some of those recommendations, including enhancing transparency, okay? And as I state these, you just let me know if you want to that, yes, I've heard that before, but we just have much the same. But really just enhancing transparency, improving direct patient care expenditure reporting, initiating CMS collections of data on payment delays and denials, basically hold CMS accountable to help have a better eye on what these Medicare Advantage plans are doing and hold them more accountable for timely payments and fair payment processes. And that when a claim is resubmitted, that it goes through the same processes that it did when the claim was being adjudicated. Because technically, you're supposed to have 14 days to give you an answer. I know some people say, well, it's 14 days to get paid, but it should be 14 days to actually get an answer. So that turnaround should be much, much faster. I understand they got to process the information you're sending you, especially if you're sending additional records and such, which I'll get into a little bit during the appeals segment of this. But it's just very important to sit back and understand the severity of this. I know many of you understand your footprint in your practice. If you don't, then you should. You should understand and know exactly how much it's costing you to rework a claim. And if you don't know, plain and simple, you just take, well, how many people do you have right now reworking a single claim? And how many people do you have, and how much time does it take them to rework that claim? So you take that FTE count and how much you're paying in salary for those particular time frames, how many hours it takes, and you divide it by the number of claims being worked, and there you have it. That's the cost per claim that you would have. And it can be very, very significant. But not only for your administrative staff, but there's also, and you'll see this in the article as well, but you may have some clinical staff involved because you may have to go back and ask them questions regarding the medical record that should have been asked before the claim was submitted. You eat up the time of the clinical staff. So you have to factor that in, which actually causes that cost per claim to go much, much higher. So some recommendations for some providers out there, obviously you need to enhance your claims management process. Now, these claims management systems have been out there for a very, very long time and they're very, very good. So when I state enhanced claims management systems, I know everyone's talking about the fact that, yep, we have a robust claims management system. They're helping us get our claims out the door, and they're very good at that, getting the claims out the door. And they look at that first pass claim rate, which is the acceptance of the claim, which is very important. If the claim is not accepted, if the claim cannot get in the door because it's not formatted correctly or has all the information in the right fields, then they're not going to even look at it. So that's a rejection. They rejected it and sent it back to you for correction. So you correct it and send it back, and now its behavior may get it denied. Many of these claims management systems may not look at it from the matter of fact, from a proactive standpoint of you need to correct this or it will be denied. So you need a system that's going to help you track all of that kind of stuff. And then regardless of technology, this is always important, is staff training and education. You need to make sure that all the staff, not just the administrative staff, but also the clinical staff, are up to speed on what is getting these claims denied, what are the root causes, and then put them in place within that RCM workflow stream to make sure that everything's being articulated. Because it's easier to correct a mistake shortly after it happens or as it's happening or prevent it from happening, say at the EHR level or the charge capture level or charge entry level or before the claim even gets to the PM system or perhaps during a pre-claim submission. Well, everyone's very familiar with claim scrubbers or having editing tools in place to make that, but those editing tools need to be up to speed with also the regulatory requirements, the updates. Some of these updates come fast and furious, especially with medical necessity policies, your NCD policies, LCD policies. So it's very important to make sure that you're up to speed on those, not just from training and staff, but also that any technical assistance you're receiving from vendors, computers and systems, whether it be your PM system or an outsourced claim scrubbing system, or even an RCM team, make sure that they're educated as well and up to speed on those regulatory requirements. And then you can use technology to help associate and learn the behavior. And when that learned behavior happens, predict, a claim that's going to be denied based on that previous learned behavior. And then before it goes out the door. And you can also put a lot of this stuff in the automation processes where you're learning it on the back end. Go ahead and share it with the front end. So it's corrected before it even gets to the claim submission process. And then also on the back end, denials. Denials are going to happen. There's no way to prevent them. They're always going to be there, but you can mitigate them in a lot of ways. And you can also make the process easier to work when you have some predictive analysis from AI, again, using machine learning from past behaviors on prioritizing which denials that you want to work. So that's very important. A lot of people look at, let's work those that are going to expire with timely filing. We got to get those claims worked first. And maybe they have the highest claim amount. And many times you'd be surprised that you're just not going to get paid for those. So through that machine learning and that AI, you can have systems like we have here at Infinix that will take a look at that and then list in priority, these are the ones you need to work first, and then they automatically assign it to your FTEs or what have you, where they can go and make that correction. So the decision's already made, and it optimizes which claims you can overturn and which ones are going to get paid faster or quicker, thus more revenue in your pocket. I also suggest that one of the improvements you have is to make sure that you reduce the days to file the claim. Now, I know in many states, it's a requirement to have it out the door at least within 7 days, or they're going to deny it anyway. So you got to get it out the door very, very fast. I think I spoke with a couple of people at this conference I attended that they get it out the door in 2 days. And that's definitely very acceptable. But the quicker you get the claim out the door, the quicker that process starts. But I hear horror stories where it just takes, 10, 14 days or so. That's just too long. So you need to process that claim as fast as possible, which means you need automations in place. You need technology in place that's going to help the coder focus on what they need to focus on in reviewing charts. The biller to focus on some of the things that they need to correct before the claim goes out the door. And some of the routine mundane things that can be automated, then let them be automated. And now you're optimizing your staff's time. where they can focus on the things that really need their attention rather than the mundane things. Also, just make sure that you're being an advocate with your Medicare payers, and not just Medicare, but also your private payers. This involves just, being in their ear all the time, putting on speed dial, letting them know what you feel, not to a certain degree, but it also goes back to contract negotiations. Make sure that you have in the contract. I think I touched on this last month as well, where the contracts is negotiations. You do have a voice in those contracts. Get rid of those evergreen policies that just roll over, but make sure that you come to the table with some of the things and concerns you've had, that when it comes to renegotiate that contract, you put those in there. And one of them is they have these timely filing stipulations on you. Then when you do an appeal or do a resubmission, they should have timely filing as well to do that response, where it doesn't take 45, 60 days, or as this report said, an average of about 6 weeks or 6 months, I should say, to get that claim finally resolved. So as you can see, there's a lot involved here in time as well as money. And when you add all that together, the money spent, the time spent, it is really, sucking the revenue stream. And what I like to call revenue integrity, a lot of people call revenue integrity. It's not a new word that I invented, but revenue integrity is very important. And this plays a big part in that. And as you can see, $10.6 billion collectively, chasing claims that should have got paid, and they did pay anyway. They should have paid with, in my opinion. Now, appeals, most people don't do appeals, mainly because a lot of the things that they appeal, they feel, oh, that's just not worth the appeal. It's not worth the effort. But in essence, it is, because it can be very repetitive, where that correction in that appeals process may affect future claims. And that appeals process, you may feel what you put into it is what you're going to get out of it. And it may take a little extra effort, but one of the suggestions that I heard at a session in this conference I just attended, is the very first sentence: please do not reply with denial upheld. That seems to be the most favorite response when you submit an appeal, that the payer will send back denial upheld. And if you start off with setting the expectations that that's just not going to do it, then you're kind of setting, the stage that you expect to have them to really consider the records that you're sending in, the documentation you're sending in, all the resubmitting of the claims, applying medical necessity. You have to bring in the diagnosis code into this, why the procedure was actually necessary, why the visit was necessary. If it's an office visit, a lot of these had to do with modifier 25, and then also another issue was prior auths. I mean, 48% of claims denied are due to prior auths. And why is that? I mean, if you're getting a prior auth, that's the whole purpose of a prior auth, is to get that claim paid. And I understand there could be denials from this because perhaps the physician turned left during the procedure because they had to, and had to change approaches or change strategy on the procedure. And the procedure that was submitted didn't have a prior auth, so it gets denied. But there are prior auths that have been submitted, but they're still denied. And that's where you just need to show proof that, yeah, this prior auth was actually submitted in time, the patient was cleared, but yet you're denying. So if you can show that proof that the prior auth was submitted and granted, that's always helpful. And then they'll try and pull, the trigger on the fact that the prior auth was submitted at a certain time period, but the procedure was too late, it expired. And that's when there's this expectation that, because it takes so long sometimes to get that prior auth back, and getting that prior auth off in a timely manner, but it's also about timing. So it's understanding what those time limits are. When does a prior auth going to expire? And so we've seen that that's the reason why some prior auths also get denials. So as you can tell in today's episode, that this is really passionate for me. Sometimes I just feel very strongly where I knock my head against the wall. I'm like, I don't understand why these denials are such an issue. I've been in healthcare for a long time, been in RCM for a long time, and these issues just resonate over and over again, whether it's prior auth, insurance eligibility, things that can be actually prevented before it even gets to the claim submission process. If it's a denial and it's something that you can utilize and get to the root cause, then leverage that root cause and create smart processes and smart edits to make sure that it doesn't repeat itself. The definition of insanity is doing the same thing over and over again and expecting different results. Well, use those carks and arcs, use those remittance advice notices, and don't just correct it. Use the reason it was denied further up the RCM chain, because it just makes sense to me to correct it at the point that it needs to be corrected rather than dump everything on the administrative level. And which kind of brings me to my last point, and I can't really express this strongly enough, is it does take the team. It does take continuity with the team. And achieving continuity means everybody's all in, whether you're a physician, whether you're a coder, whether you're a biller, whether you're a practice administrator, whatever your role is within the practice, everyone's goal should be to maximize the revenue, to make sure that the RCM workflow and that requires often meeting together. Again, that prior auth example, my question would be, does your patient access team get prior author or see the denial reports? Do y'all communicate about that? How the patient access team can help alleviate these denials later down the road, or how the claims submission team, claims processing team can go to the patient access team. So it takes communication between departments and do it on a regular basis and have really upfront conversations about how this can be improved. Not in a way that where you're trying to demean others or point fingers that they're not doing their job correctly, but really have an attitude of, hey, we're just trying to make our jobs better. We're trying to make sure that the revenue that we're bringing in the door is going to increase. So communication, regular meetings that are effective, productive meetings that are going to remedy and help improve your revenue integrity. So I always encourage questions and answers. I think one question that I can actually start off with while we're seeing if anybody wants to add a question would be, well, my vendor just won't cooperate. How can we get vendors to do what we want or do what we need per se when it comes to helping? Because, we have interoperability. It's been around for, gosh, almost well over a decade now. And it's come a long way, but it's still got a long way to go. Many vendors still live in a proprietary world, obviously because of the competitive nature of the market. There should be standard files, standard information, standard data that you can communicate. Many practices have a PM system that probably doesn't integrate well with their EHR. We know hospital systems have multiple EHRs they're having to contend with on the ambulatory level with their physician groups that they own. Obviously, if you're dealing with an Epic or something like that, it's very robust and very universal from the hospital side, but is the hospital side communicating with the ambulatory side? So there's a lot of integration issues. And just like I stated earlier, that you have to get all your team members in a meeting, but you also have to get all your vendors in a meeting. And even though they can be competitive, many times the most of the ones that I've dealt with, and I've had many experience in integrating and help interfacing with different EHR systems, different PM systems, getting everyone at the table who you would think on first glance are enemies, but when they all collectively come to A, they all want to take care of their customers, and B, they definitely want to make sure that the patient care is being delivered. You'd be surprised that you can get them all in the same room and have similar meetings, similar discussions on how everyone can work together, because they all like to point fingers. But when they get together, the finger pointing stops and they start coming up with solutions. So I would encourage you to be sure that you hold your vendors accountable to what the expectations. Look at any contracts and support agreements, SLAs that you have, and make sure if you're entering into a contract with a vendor that you have an appropriate SLA that will accommodate that any future technology advancements will be quickly remedied and that they will consult with you on those. So here we go. We have one here also that's in that all hands meeting, KPIs to review. Yeah, that's an excellent question. And there are the usual suspects KPIs. There would be things like what's the denial rate, but also I like to look at, days in AR obviously is great. You can see what backlog you have. Also, perhaps the time it takes to get a claim out the door would be an excellent KPI, because how can you alleviate making this faster and moving it forward? You can also have, and an example I have with the prior auth team, it really depends upon the team that you're meeting with, and you want to stress the KPIs that are meaningful to them. So you would definitely want to have a report, say at the patient access level is, okay, here's how many prior auths that went out. Here's how long it took to get that prior auth back. Here's, the status of that prior auth, how many were denied, how many were actually granted, things of that nature. And then correlate that by the encounter with if it is denied on the back end. You go back and then y'all can talk about, okay, well, this is the procedure that was submitted for the prior auth. This is the procedure that was actually filed. And it was a situation where it was not a left turn by the physician. It is that was the procedure that was planned. So did you file the wrong procedure with the prior auth? That happens. So you just need to make sure you also break it down by procedure, the prior auth, and also by certain payer types. So those KPIs are very important, just as an example between those two teams. That's an excellent question. I really appreciate everyone's attendance. I had a really great turnout today. And as always, please reach out to us. If you have any additional questions, you can check out our website and go and even request a demo, request additional information, whatever you want. We'd be happy to talk to you specifically and understand your goals and your objectives, as well as the issues that you're having, to see if we can give you any further advice on how you can prevent denials from happening to begin with. So meantime, we encourage you to join us and sign up for next week's office hours. Till then, we'll see you later, and everyone have a great day.
Thanks for joining us. Subscribe to get notified when our next episode is online. For more information for how we can help you increase reimbursements at your company, check out our website at infinix.com. That's INFINX.com.